Hello, everybody. It's a great pleasure for me and my co-presenters to introduce you to the first webinar of the anterior segment group of ERN-EYE. And the topic today is corneal dystrophies. And the first presentation will be on the phenotypic side of things. Then we will have a presentation on the genetics, and the last but not least presentation will be on therapy. And let's start with the first presentation. And my name is Daniel Böhringer, and I will present you the clinical appearance of corneal dystrophies. And the cornea, as you will know for sure, is a tiny structure with a diameter of around 11 millimeters, and its thickness is 0.5 millimeter. And it is, you can think of it as a windshield of the eye, and it has perfect clarity and has a perfect dome-shaped curvature. And this makes it the most powerful optical device of the eye. It's 4 times or 3 times more powerful, for example, in comparison to the crystalline lens. That's also important for refraction. But the cornea is much more powerful and more important for refraction. And this is due to the highly regular ultrastructure that comprises of from the outside to the inside of the epithelium, and then with the basement membrane of the epithelium, it's the Bowman's layer, and then there is the stroma. And on the other side, towards the interior face of the eye, there is the corneal endothelium resting on Descemet's membrane. And if this highly regular structure is somehow disturbed, we always for sure get a disturbance of visual function. Even at the more in the center, the more relevant. And one cause of these disturbances can be corneal dystrophies. Corneal dystrophies are mostly inborn diseases. It's a group of diseases that share that they are mostly inborn. They commonly are progressing over life, but their onset is variable. We have some diseases that present at birth, others present in the 5th decade or even later. And most of these go along with decreased vision. Some make you glare, and some are painful, but others are indolent, as we will see. And it makes sense from a clinical point of view to group the corneal dystrophies, and we have more than 30 of them, according to the structure of the cornea that is primarily affected. And this is, let me start with the epithelium and the Bowman's layer. And we have here, I think, more than 10, but I will not read them all at this time. We will revisit this slide later. But if we move along in the stroma, we have less than in the epithelium. And if we look on the endothelium, we only have 4 of them. So it's from outer to inner sort of decreasing complexity. But if you maybe remember your own board exam, if you're an ophthalmologist or the medical students, they all sort of are worried when they have to learn all these and differentiate between these. And some even get a moment of crisis. So let's have on how to optimize this and get a systematic approach. And for that, we will focus on the complex group of the epithelium and Bowman's layer. And you can see here that the phenotypic appearance is a big clue on the diagnosis. So we have the epithelial basement membrane dystrophies where you can see in the slit lamp that there are these curved lines that are duplications of the Bowman's layer, so the basal membrane. And there is a unique pattern that is from Lisch dystrophy, where that's one that is mostly indolent, where you have only hazy, sharply demarcated opacities in the superficial layers. And then there are the mucinous dystrophy, for example. This is the third image from the top, where you have really strong alterations and prominence. And in the last, there's a clear surface, a smooth surface, and you have the opacities in the anterior stroma. That is an example of corneal dystrophy. That is the first clue to some of these are really easily recognizable, but some of them appear in the same way in the slit lamp. So you have another clue, that is the symptoms and the signs. So if you ask the patient on pain, and this is mostly due to recurrent epithelial erosions, you will see that there is a big cluster where this is an issue, but there are some where it isn't. And in turn, there is the pattern of stromal opacities. This is sort of an overlap with the second category from the stroma, but these are, from a systematic point of view, also put in the epithelial group. So these then make the diagnosis quite clear if you have this. And you can do this in a more systematic approach and make yourself a matrix where you have a line for each of the dystrophies, and then the features in the columns. And then you can go through and find the diagnosis, more or less. But this is really complicated, and it's not easily handleable for the practitioner, I think. And so we wanted an electronic tool that does it for us automatically. We want to have a guided collection of medical history of the symptoms and clinical findings, and then the computer should compare all the options and give us a weighted list of the most probable diagnoses. And we also want to have links from these, so we can undermine our finding and make ourselves confident that this is really the issue of the patient. And actually, we have done this from the ERN-EYE in the anterior segment group, and this is a quick QR code to get there. But I will show it again on the last slide, so no need to hurry right now. And now let's go through this in an example. This is a patient in a 6th decade with slow progressive visual loss, and the symptoms are more severe in the morning, and she has a moderate decrease of visual acuity. And when you go to this QR code, you get the questionnaire, and this is paged, and the first page has 3 questions, and you can easily answer them. The onset is given. We have no clue on inheritance, but we know that is progressive. Then we move to the next page, and here are the clinical the signs and symptoms, and we only know that she has decreased vision, and none of these others are reported. So we only click the decreased vision, and no systemic associations are mentioned. We go to the next and last page of the questionnaire, and here we have to enter the slit lamp findings, and in this case it's only the endothelium that has these guttae. You can see it in the backlight from the fundus reflection the easiest. And if we now click on the complete, we get this list I promised you, and the first one is Fuchs endothelial dystrophy, and this makes perfect sense from the symptoms and the clinical finding. And if you click there, then you get redirected to the iWiki of the AAO, And there you can get deeper into this disease and make sure that's actually the right one. If you don't feel confident that this is the case, you can go back and click the second one and so on until you maybe are sure you got the disease or not. You can learn a lot on this way. And this is really only for education. It's not for clinical use. So I think this tool will help getting there if you need to find the differential in signs and symptoms. And this is the QR code to get there, but remember it's not for clinical use because it has no CE mark, at least not for now. And you can, I think, get the slides later or in the recording and you scan the QR code there. So I think we can just move on, and I give the floor to Petra Liskova from Prague University, who will present on the genetics of corneal dystrophies. And the floor is yours, Petra.
Hello, Daniel. Hello to everyone attending this webinar. So my presentation is entitled Molecular Genetic Mechanisms Underlying Corneal Dystrophies. So genetic research has made a huge impact on our understanding of corneal dystrophies. As you may know, in 2008, International Classification of Corneal Dystrophies was published, and this for the first time incorporated also molecular genetic knowledge. Corneal dystrophies started to be classified into 4 categories, for which C1 is a well-defined dystrophy with the mutated gene or genes identified. C2 is well-defined with MEP locus, whereas C4 is only a new, considered to be new or suspicious corneal dystrophy with not convincing data on its existence. This slide shows a current overview of known corneal dystrophies and only entities that have high level of molecular genetic evidence, such as known gene or MEP locus, as per online Mendelian inheritance in men are listed. Unlike inherited retinal disorders, it's very, from my point of view, interesting that many patients with corneal dystrophies still do not get offered molecular genetic testing. One of the reasons might be that corneal dystrophies are viewed as surgically treatable, thus you have something to offer to the patients. Most corneal dystrophies are inherited as an autosomal dominant trait, and thus examination of first-degree relatives is recommended as their clinical findings may provide additional clues to achieve a correct diagnosis. Pathogenic mechanisms involved in corneal dystrophies differ depending on the type of corneal dystrophy and involve structure disorganization, cellular instability, or maladhesion, aberrant protein deposition, abnormal cellular proliferation or apoptosis, and dysfunction of normal enzymatic processes. Below are some examples. So, for example, mutations in keratin genes cause defective cytoskeletal structure, leading to intraepithelial microsis filled with degenerated cellular debris, which leads to epithelial fragility, recurrent erosions, and at the end to visual disturbance. Some mutations in the TGF-beta gene cause amyloid deposition in the stroma that look like lattice lines, and again, visual loss occurs. Whereas mutations in GST6 are or lead to defective keratin sulfate sulfation, which further leads to accumulation of glycosaminoglycans in cornea, and again, corneal opacity or clouding can occur, leading again to visual loss. So last example are mutations in COL8A2, which lead to endothelial cell dysfunction and their loss, followed by fluid accumulation in the stroma, and again the resulting is corneal opacity leading to visual loss. So why should we perform molecular genetic analysis in corneal dystrophies? First of all, because it should be our aim as clinicians to provide the patients with precise diagnosis. In monogenic condition in general, but it's always a discussion with clinical geneticists and other people involved in the process, one can offer to the affected families pre-implantation genetic testing. It's also good for our general knowledge to learn about pathogenic mechanisms. And lastly, innovative therapeutic approaches are under development, including RNA interference, antisense oligonucleotides, etc. And for this innovative therapies, identification of the underlying molecular genetic causes is a prerequisite. So now I would like to further demonstrate, using our cases, why we actually need genetic testing or how genetic testing can be useful. So we have 3 patients shown on this slide and all have some lattice lines in corneal stroma. So naturally, we undertook TGF-beta eye screening because it's the most common cause of lattice corneal dystrophy. We see lattice lines. So in the middle patient, we did identify disease-causing mutation by screening this gene. So the final diagnosis was variant of lattice corneal dystrophy. In the first patient, who was noted to have lattice line already when he was 24, it took no longer than 20 years to actually find the cause of his disease. But initially, after TGF-beta eye screening, to our surprise, he was negative. Then, after these 16-20 years, we had an idea that perhaps, although he was very young at the age of manifestation, 24, perhaps we could perform systemic examination, and we got to the diagnosis of paraproteinemic keratopathy. I think it's the youngest case with paraproteinemic keratopathy described, with the youngest onset. In the third patient, again, we didn't find any TGF-beta mutation. However, after several years, although the patient did not have any systemic signs, we performed screening of the gelzoline gene and did identify heterozygous mutation explaining this phenotype. So the final diagnosis was familial hereditary amyloidosis. Another example showing the utility of molecular genetic analysis is a sporadic male patient with bilateral congenital edema and no family history. So below are all the possibilities that he can actually have. So which one would you choose? So the most likely diagnosis is congenital hereditary endothelial dystrophy. However, there were also cases described with congenital corneal edema carrying ZEB1 mutations, confirming that the patient had a de novo occurrence of posterior polymorphous corneal dystrophy type 3. Other options are congenital glaucoma, also congenital cytomegalovirus infection. The patient can also suffer from X-linked corneal endothelial dystrophy. And there's always a possibility that there are some novel molecular genetic causes, because only this year, 2 novel genes, or actually last year in 2024, 2 novel genes for corneal endothelial dystrophies were published. And the last case shows a very difficult patient who actually had a dual diagnosis. So by performing molecular genetic testing, we were able to prove that he has posterior polymorphous corneal dystrophy type 3, in addition to Snyder corneal dystrophy. So I guess because both of these disorders are very, very rare, the chances to win the lottery compared to having 2 different rare corneal dystrophies are probably higher. The most common corneal dystrophies, except for Fuchs corneal endothelial dystrophy, are TGF-beta eye associated disorders. So mutation in this gene lead to at least 5 different phenotypes. And again, without molecular genetic testing, the correct diagnosis can be very, very difficult. Now I go back to the patient that was already shown, hereditary gelzoline amyloidosis. The current IC3D classification has excluded this type of disease from corneal dystrophies. Previously, it was referred in many books and papers as lattice corneal dystrophy type 2. However, the patients in initial stages it's undistinguishable from classic lattice corneal dystrophy. So again, genetic testing is very helpful. Although these patients, when they get older, they do get other polyneuropathy, etc., which can add to diagnosis, but younger patients don't. So this disease is relatively common in Finland. However, otherwise, it's very difficult to diagnose. I've counted in the literature that less than 10 families were described, and of these, we collected 3 to Czech and 1 Slovak. And for this, it is very important to make the diagnosis because of the other symptoms. The patients have need to have regular check of heart, kidney, etc., and then they can get some help with cutis laxa, eyelid drooping, peripheral neuropathy. So one of the members of this family was actually had in his nose that he was suspected to abuse alcohol, which he did not. We just had peripheral neuropathy, and nobody knew what was the cause until we performed the genetic testing. So one of the disorders that needs to be also mentioned specifically is Fuchs endothelial corneal dystrophy, because it's not a rare disease, but it is the most common cause of corneal grafting, and 80% of these cases, they have an expansion repeat in TCF4. However, when you actually look at this, you still have 20% that do not have this expansion, and these actually may have other more rare genetic causes. So when you dissect this disease into molecular genetic causes, some forms can be very rare. It may be of surprise to you that Fuchs endothelial corneal dystrophy is the most common repeat-mediated human disease, and that more than 50 human diseases have been attributed to expansion of repetitive parts of the genomes, but Fuchs has this privilege. In addition, it's an attractive paradigm also for neurologists and other for modeling disease mechanisms and testing therapies, because it affects accessible tissue and it's age-related. So what is the strategy for molecular genetic testing of corneal dystrophies? So I guess currently massive parallel sequencing, usually covering either a physical gene panel or exome sequencing from which you can extract the desired gene panel, is performed, but you can also perform, or we also perform genome sequencing if we want for discoveries. Mainly we research for novel genes or mapping of deletion breakpoints. If you based in a settings where it's not reimbursed or you don't have enough research money, there's always an option to perform for some of the diseases just Sanger sequencing. For example, as I already mentioned, the most common are TGF-beta-I corneal dystrophies, and most of the mutations are located in exon 4 and exon 12. So by screening just these 2 exons, you may have a fairly good yield of identification of the molecular genetic cause. Sanger sequencing is also used for non-coding variants if it's not covered by panel or exome sequencing. So the most, from my point of view, common examples are promoter mutations in OVOL2 causing posterior polymorphous corneal dystrophy type 1, or grainy headlight 2, where the mutations are also located in non-coding regulatory region. If you search for which genes to screen, I think very good tool is Panel Up from Genomics England. You can see the slide on the slide. Currently we have version 4.1 and it's curated, so you can have a look there. And it shows that 22 genes are so-called in green. That means there is no doubt about their disease causing, that they are disease causing, and 2 genes are in red, which means there are doubts that they are disease causing. For some diseases, you need to perform copy number variation analysis. that there are several options. I think nowadays, if you go for gene panel or exome sequencing, the first try would be bioinformatically from massive parallel sequencing data. But there sometimes for some of the genes there may be multiplex ligation dependent probe amplification, or in my opinion a little bit all the way would be quantitative polymerase change reaction. For Fuchs, we perform genotyping of the expanded repeat, which is again intronic, and we start with short tandem repeat analysis and followed by, in selected cases, by triplet repeat prime PCR. And what I've just learned at European Society of Human Genetics meeting in Milan this year, PacBio has also included the TCF4 on their pure target kit. So, given that the diagnosis at DNA level is, from my opinion, the most reliable, what prevalence of individual corneal dystrophies can you expect? In other words, how rare are these disorders? So we've been collecting patients in the Czech Republic, which has a population until the Ukrainian crisis around 10.5 million inhabitants for a long time. So our data can be a little bit used for as a model for an outbred population. And as you can see, and as expected, we found 12 families with TGF-beta associated corneal dystrophy, so nearly the most common group. Then we formed 19 families with PPCD3, and because they have different mutations, so this prevalence rate can be used. As for PPCD1 and PPCD4, the situation is different because this is influenced by founder effects. Similarly, for example, founder effects are very often present in Finland or Sweden, as for ERED. So sometimes you cannot really rely on one data from one population. We have then, as for the rare dystrophies, we had 4 families with Meesmann corneal dystrophy, 3 families with gelatinous drop-like dystrophy, 19 families, which is actually the second most common macular corneal dystrophy, 6 families with Snyder, 1 family with fleck corneal dystrophy, and 7 families with congenital hereditary endothelial dystrophy. So, as you say, they are all rare, but you can find them definitely. And what you have to bear in mind, that prevalence may differ in population with a higher rate of consanguineous marriages. For example, in India, Czech is far more common. And founder effects, also the general prevalence. And I've showed you the example of PPCD1 in the Czech Republic, which has a common founder around the town called Klatovy, or ERED in Sweden, or other diseases. So now I get to conclusions. From my point of view, all patients with a suspected corneal dystrophy should undergo genetic testing, as clinical description alone is often not sufficient. In sporadic patients, especially when elderly, you should exclude paraproteinemia, and sporadic means there's no family history. Of course, except for Fuchs, which is readily identifiable. So in any sporadic patients with stromal or sometimes even epithelial weird opacities, bilateral. Prevalence of different corneal dystrophies may vary and can be influenced by founder effects. And the most common in general outbred population are TGF-beta associated corneal dystrophies, macular corneal dystrophy, and Fuchs endothelial corneal dystrophy. And then if you search well, also posterior polymerase corneal dystrophy type 3. So now I'd like to thank you for your attention with this nice view of Prague, which is actually made from our department. And I would like to invite the last speaker, which is Luca, who will be talking about surgery or surgical management of corneal dystrophies.
Thank you, Petra. Good afternoon, everyone. I'm sorry, but with this presentation, I will not give you a defined association between each corneal dystrophy and a possible surgical treatment, because the approach is related to the site of the dystrophy. So if it is epithelial, it is stromal or endothelial. It is estimated corneal dystrophy affects 0.09% of US population, and in 60% of cases, the dystrophy is of endothelial origin, but it's very different, the possible treatment, because we can simply monitor it or treat with PTK or a keratoplasty lamellar or penetrating. In 1995, PTK was approved for the treatment of anterior corneal dystrophies, but up to now, there is no standardized ablation depth protocol. Different is the setting proposed, but poor are the sample of patients enrolled in the study. This is a very recent paper, and as you can see, 35 and 20 represent the maximum of patients enrolled in the study. This paper evaluated the efficacy of transepithelial PTK for treating recurrent corneal erosions, and 65 microns was the depth set, but 50 microns for epithelial removal and 15 microns for subepithelial treatment. In this other paper, the stromal ablation is limited to 5 and 5/8 microns. In my experience, I began to the refractive surgery with excimer laser in the early 90s, and for PTK, I think the parameter that really can drive a surgeon is the sound of the single spot on the corneal surface. And nevertheless, technologies progress. These remain the basic evaluation system for PTK. The mitomycin use is not largely reported for corneal dystrophy treatment, but obviously PTK is a less aggressive treatment, and mainly in pediatric patients when amblyopia treatment is the first problem. The fast recovery provided by PTK could be a very good advantage. But when the depth of the dystrophy site increases, obviously the surgical approach have to change, and depending on the depth of the layer involved, we can perform an anterior lamellar keratoplasty or a DALK with a stromal dissection or a Dashpet bearing, usually achieved by big bubble technique. I'm working in a children's hospital, and we some years ago published this paper with that evaluated the follow-up, mean follow-up 22.8 months of 54 pediatric keratoplasty. The mean age of the patient was 8.9. Summarizing our results, showed that for patients youngest than 5, we observed a graft failure in the 80% of cases. So the age of 5, for our experience, represents the threshold for performing a keratoplasty. About the surgical technique, for all sample evaluated, we recorded a statistical difference between PK and DALK with PK worse than DALK. But analyzing the patients in function of the age, we did not observe a significant difference, but in the individual cases, DALK resulted always the best surgical choice. We know that B-bubble technique represents actually the standard for DALK procedure, but safety, standardization, and repeatability represent the the main problem and for this surgery. I worked for several years with femtosecond technology and try to develop a standardized big bubble technique. This that we call big bubble full femto represent our final results of full standardized big bubble technique assisted by femtosecond technology. We applied a metal mask diameter, a metal mask of 9.5 millimeter diameters with a fissure of 0.7 millimeter corresponding to the width of the canal for injection in the cone for docking. Then the laser performed a ring lamellar cut 100 microns above the thinnest point with an internal diameter of 3 millimeter and an external diameter of 8 millimeter. And you can see in the slide, the laser could work only in the open area, so providing the creation of an interstromal channel for the cannula insertion. Then an arcuate incision of 30-degree arc depth provided the entrance to the channel from the corneal surface. Then the laser performed a full lamellar cut 200 microns above the thinnest point for create the lamella. We can directly insert cannula for injection without other previous surgical maneuvers with a resistance due to the adhesion of stromal fibers, but achieving in a very high percentage the bubble. The OCT image is catched immediately after the laser works. As you can see, is clearly represented. The lamella is the upper, the superior line, the channel, the inferior line, and the arcuate incision that connect the surface to the intrastromal channel. The advantages of a systal big bubble technique are many. We are at the predefined corneal depth. The learning curve is reduced. Some residents successfully perform this technique. We have a good big bubble percentage, a standardized surgical time, a decreased risk of inadvertent perforation. In case of conversion to PK, all the advantages provided by femtosecond technology. The disadvantages are all economics because of the poor reimbursement patterns of our national health system, the need of a key operator, and a longest occupation time of the operating room. I at first applied this technology to pediatric surgery, and in case of smallest eyes, we successfully, this is a live surgery of some years ago, successfully experimented the docking without suction ring by fixing ocular bulb by conjunctival stitches suture over the skin. And this technique provided a safe and effective applanation. This is a patient, the pre-op, 6 months old, a 7 years follow-up. The femtosecond laser makes easier in DALK the accuracy in donor-recipient cut, the knowledge of the depth, the decrease of learning curve. It makes easier the suturing and also the treatment of some challenging cases. What the femtosecond laser makes safer to minimize perforation, decrease the risk of conversion to PK, to provide lower rejection rate, to provide higher endothelial cell density. In the future, the technology development of femtosecond technology could achieve the chance to reach a deep thickness without the need of air injection. Coming back to our dystrophy, this is an anterior dystrophy that I treated with a big bubble DALK. But in some cases, especially if there are some scars or deep opacity, could be difficult to achieve a bubble. So a layer by layer technique could be indicated. And the main difference is related to the quality of the interface. On the left side, you can see the cornea after a big bubble DALK, and on the right side, a cornea after a layer by layer DALK. The femtosecond laser helps very much in an anterior lamellar procedure, because could be possible also just removal the lamella and replace it with the donor with a very easy and fast procedure. Obviously, in function of the depth, change the roughness of the surface. But in my experience, with a good management of postoperative astigmatism, it is possible reach, not always, but often, a good result, as well as in this patient. We started with 11 diopters of astigmatism, and about in 1.5 years, the astigmatism amount greatly decreased. But in case of involvement of the stroma, we have to perform a penetrating keratoplasty. This patient is a 42-year-old patient with a granule, with important edema, and visual acuity decreased 0.2. After penetrating keratoplasty, the visual acuity increased until about 0.6. I performed the transplantation about 4 years ago, and up to now, I have not yet observed a recurrence. In some cases, however, for example, in this posterior polymorphous corneal dystrophy with an endothelial involvement, in my opinion, is better to perform directly a penetrating keratoplasty because of the damage of the internal cornea, the posterior cornea. This is a case of CHED. 10-year-old female was sent to me with a cloudy cornea, and I diagnosis performed when she was 2. I performed a DMEC, but in my hands resulted very difficult, the endothelial stripping, because of the tight adherence between endothelium and stroma. So finally, I achieved a partial clear cornea. But anyway, the visual acuity arrived to 0.2. So considering the deep amblyopia, finally a good result. In conclusion, this case report that I think crosses our 3 presentations. This 26-old patient, male, was sent to me with a diagnosis of keratoconus, a diagnosis when he was 20, a progressive decrease, no inheritance, and but in my opinion, this not was really a keratoconus because of this endothelial opacity that corresponded to a posterior polymorphic corneal dystrophy. Anyway, I performed a penetrating keratoplasty with a good result, a good outcome. Keratoconus, no. Posterior polymorphic dystrophy, also because of the clinical history of this patient. But arrived the child of this man. He was sent to me when he was 6 months with a diagnosis of congenital glaucoma. He was he had a bilateral corneal cloudy with a jerky nystagmus. You can see the parameter recorded during the examination under anesthesia. In my opinion, this was a suspected Czech. Comparing father and child, we have a father with a symptoms onset when at 20 years of age, endothelial opacity, corneal ectasia. A child with symptoms onset at birth, corneal edema. In the first case, suspected the PPCD. In the other case, suspected Czech. The genetic exam surprised us with a diagnosis of posterior polymorphic corneal dystrophy also for the child. So effectively, genetic exam changed totally our the opinion that clinical evaluation did. Thank you for your attention.
So if there are no other questions, I think we could finish this webinar.
So thank you very much for your participation.
Thank you.
Thank you, too. Bye.
Bye.